Gossip.
This is Polyp Gossip, the place for physicians and patients to catch up on what's hot and what's not in CRS with NP or nasal polyp syndrome.
Welcome, everyone, to this very first episode of Polyp Gossip, where we dig deep into the latest trends, topics and controversies in the field of rhinology and more specifically chronic rhinosinusitis with nasal polyps or nasal polyp syndrome. This podcast is developed by Sanofi Regeneron and also elaborated in close collaboration with EUFOREA. I'm Dr. Peter Hellings, ENT surgeon at University Hospital in Leuven, Belgium, and I'm very happy to have a co-host today, which is Professor Dr. Wytske Fokkens from the Academic Medical Center Amsterdam, also EPOS chair at EUFOREA. We are very excited to kick off this first episode of Polyp Gossip, where whether you're an ENT specialist or a patient, you will enjoy the gossip around the latest trends in nasal polyps and how some of our colleagues consider sinus surgery or biologics for their patients suffering from chronic sinusitis with nasal polyps. Because the question whether or not one surgery is enough for those suffering from severe uncontrolled CRSwNP is really a big matter and a big topic for those dealing with these patients as a healthcare professional as well as for patients themselves. And to render this debate even more dynamic, we are supported by a top rhinologist from Italy, Professor Dr. Eugenio de Corso from the University of Rome, who will help us guiding the discussion around these novel topics in relation to nasal polyp syndrome. For patients, it's of course a big decision whether or not to undergo revision surgery or to get embarked on biological treatment. And therefore, we are having this Polyp Gossip show on this relevant topic. So in order to make you understand the pros and cons of sinus surgery and the pros and cons of biological treatment, let's get this first episode of Polyp Gossip show started. And I would like to start this Polyp Gossip with the first question addressed to Professor Eugenio de Corso, which is about sinus surgery and what he expects from sinus surgery and how he communicates about sinus surgery towards his patients.
Thank you, Peter, for this question. I think that it's very important to explain our patient that the first surgery is very important for several reasons. The first reason is why you can decrease the load of inflammation, removing all pathological tissue, and you can improve quickly the symptoms, especially nasal obstruction, and in some cases you can improve smell, but improving smell is not so guaranteed with surgery. And we have to explain patients that even the penetration of local steroids after surgery is better, so we can obtain even better results with the application of local steroids.
Well, Eugenio, I think that's very clear, and I fully second that. Can you tell me, what do you explain to your patient when you have to do surgery again? And then there are two situations. There is the situation that you have to do your own surgery. And I would like to hear what you say if you revise the surgery of someone else.
This is even much difficult because to explain the first surgery is much easier than explain the need of a revision surgery. In that case, it's very important the concept of adequate surgery, because actually we are facing with this problem, because in some cases, surgery was not complete. For example, ethmoid was not completely opened. And in that case, if surgery was not complete or was inadequate for several reasons that we cannot discuss now, but there are reasons why surgery may have been performed not adequately, in that cases, we have to explain our patients that the long-term benefit could be better with an adequate surgery. But in those cases, Sometimes patients don't trust much surgery because they were failing with surgery before. So this is it's very unsuccessful to have a failure with surgery, because patient will lose the trust with surgery. So for that reason, this is one major problem why they don't want repeat surgery and they prefer other treatment. We can explain them that the surgery could be done better, but it's very difficult that they would accept another treatment. It depends from the patient priority and patient preference.
I always discuss with the patient very clearly what the goal of my surgery is. Why do I want a revision? And what is the symptom I want to improve, or the excess I want to improve? And then, of course, it's easier to explain, to say, well, we had this goal, but we didn't reach it. And I think the reason why we didn't reach it is this. And we could probably try again and improve that situation. And then, of course, a very difficult decision is, what do you say about smell?
Oh, that's really difficult. And I usually used to tell them that we can improve smell, but not so long term. I cannot guarantee with surgery a long-term control of smell function. And this is one of the major reasons why they don't decide to repeat surgery. But I think smell is one of the major driver of severity in these patients, especially for the negative impact on quality of life. And we have to establish, even if smell is one priority for the patient, because when smell is one priority for the patients, okay, it could be not so good to repeat surgery, even because you can do a damage of olfactory cleft. This is very difficult with surgery, but we have to take into account that it could be happen. And for that reason, probably biologics could be a better option in these cases when smell is a priority for the patient.
Thank you, Eugenio. We all agree that at this moment we are experiencing a revolution of care in the field of CRSwNP, because we have more treatment options than, let's say, 10 years ago, with less oral corticosteroids, with maybe also less revision surgery needs. But what I want to ask you and discuss is how you see the inflammatory component of CRSwNP in relation to the treatment options that we have. We all know that inflammation drives nasal polyp inflammation and nasal polyp development. It drives also the nasal polyp size. And we also know that in other conditions like atopic dermatitis, allergic asthma, and even in other chronic inflammatory conditions, if you don't tackle the inflammatory component, the disease might not be well controlled. So how do you see surgery in relation to the inflammatory component of chronic rhinosinusitis with nasal polyps?
I think this is a very interesting question, Peter, because in my believing, it's very important, the load of inflammation. So we know that this disease is very heterogeneous, and for this reason, the spectrum of severity is very heterogeneous also in these patients. So you can have patients with a low load of inflammation, and in that patient, probably surgery plus a controller of inflammation, such as local corticosteroids, may be benefits. We don't know how long, but maybe benefits much better than in patient in which we have a very high load of the inflammation. And in that patient, surgery plus local corticosteroids could be not so effective in the other category.
Yes, I also think, Eugenio, that we, of course, are very biased because we work in tertiary care where we always see patients with very severe inflammation and a lot of symptoms. But it's very good, I think, to realize that actually proper surgery plus anti-inflammatory treatment with nasal steroids, for example, is a very effective treatment. And in more than 80% of the patient, it works. So especially for patients, I think it's important to understand that that's not a step we should skip, because it really helps most of our patients. Of course, if you work in a tertiary care situation like the three of us do, you sometimes think surgery is never any good, but that's because we collect the spectrum of very severe patients. Do you agree, or anything you would like to add?
I agree with you. And I think also that we should explain our patient how are important comorbidities. Because in some of these patients, especially in tertiary care, as you explain, the comorbid severe asthma is very common. And in that case, is to treat patients with biologic instead of repeat surgery is highly suggested, and because with one treatment you can treat two diseases, and for that reason I think that in this situation it's very important to have a multidisciplinary network, and we are lucky because we work in big hospitals, so it's very easy to have a multidisciplinary group. This is much difficult in peripheral hospital, on a smaller hospital, where there is not, for example, all the categories, all pneumologists, allergologists, and ENT in the same hospital. So it could be much difficult, but it's very important to analyze the comorbidities in these patients, especially asthma, and establish if there is a moderate not controlled asthma or even a severe not controlled asthma, because in that situation it's very important to start with biologics.
Okay, I fully agree with what has been said. We tackled already the aim of surgery. We mentioned already that nasal polyps are driven by inflammation that gives rise to persistence of disease and might give rise also to recurrent disease. What is, according to your opinion, in a very short statement, the aim of biological treatment that we nowadays advocate for patients with severe uncontrolled sinus disease that fail after sinus surgery? So, Eugenio, what is your opinion on the aim of biological treatment in this patient population?
I wouldn't see again to repeating surgery without any sense in that patients. I have met in my life people that had surgery 11 times, 14 times, 15 times. This was harmful for the patients. So I think the new reality is much better for them. And I don't like to see patients that repeat systemic steroids or long-term systemic steroids having complication in a short time and even long term. So the first aim for me is to stop the vicious circle of repeating unuseful surgery. The second aim is to stop the need of systemic steroids, and obviously is to get the patient in a better situation without symptoms, especially without nasal obstruction and with a good sense of smell. And this is another important aim that I want to reach with biologic. And as I told you before, if there are comorbidity, have the possibility even to control comorbidities.
Okay. Wytske, in what kind of patient population do you see the highest need of biological treatment, and would you opt for biologics versus revision surgery?
Yes, Peter, that's of course a very, very important question. And for that reason, within EPOS and EUFOREA, we made criteria to help our colleagues when to consider a biologic. And we said, well, there are a number of criteria. So first, patients have to be operated, and that's not because we think a biologic will not work if the patient is not operated, but because surgery is very often an effective treatment. But if surgery is not effective, then we want impact on quality of life. So the patient is really suffering, loss of smell, comorbidities like asthma, nasal polyps, of course. Eugenio, help me.
Yes, I want to help you, because I want to stress that sometimes the time of recurrence is very important, because you can do surgery and have symptoms after 1 year, just after surgery, or you can have a long-term benefits with the first surgery. This is a different scenario, because if you have a good results long-term with surgery, for example, 10 years of benefits, in that case, is why not to repeat surgery. But if you don't, and especially in some patients, we can have recurrent symptoms in 1 year, and there are some nice data showing that if there is not a good control within 3 years after the surgery, there is a higher possibility that you are facing with a patient with a severe chronic rhinosinusitis, and probably he will fail again with surgery in a short time. So in that context, I think even the time of benefits after the first surgery is very important. And the second things are anatomical sequelae from the first surgery, because if you have a mucocele of you, if you have an important septal deviation, for example, of some synechia that you have to correct surgically, this is another situation, and you have to repeat in these cases surgery.
These are all. Yeah, please, Wytske.
Well, I would like to add that you asked us what's the aim of using a biologic, and I think what we cannot achieve with surgery in a certain population of patients is to really reduce inflammation. And it's wonderful to see if you give a biologic that in some patients, for example, smell comes back in days. And that's also a very clear indication that the loss of smell is not caused by obstruction of the polyp. So it's not polyps being in the way. It is the inflammation of the olfactory epithelium, of the part of the nose where you actually can smell, that is attacked or improved by the biologic. And I think that is a clear indication of the importance of reducing inflammation, not only as in a sense of comorbidity, but also within the sinuses itself.
Wonderful. I like this discussion, and you see that there are so many considerations around sinus surgery on the one hand and biologics on the other hand. And now I may ask a kind of challenging question which relates to the pros and cons of each approach. And what are the 2 pros and 2 cons you would inform a patient about? If you choose, for instance, for revision surgery, what do you inform a patient about as being the advantage and disadvantage of surgery? And just limit yourself to the 2 major pros and the 2 major cons. And I hand over to Eugenio first, and then Wytske. This is a challenge, but what pops into your mind? So please share that, Eugenio.
This is a very difficult answer. I think that I will discuss with my patient that surgery is one shot. And this one-shot treatment, and you can have a different long-term benefits. And this is the point, that actually we cannot imagine how long the patients could be benefits from surgery. Because some patients can have a long-term benefit with surgery, and obviously this is very good for a patient to have a long-term benefits, having a free time from drugs, from biologics, and this is one point. But if there are some predictors of severity and of failure Obviously, I would prefer to start with biologics. This is a very important topic because actually we don't know very well what are the predictors of a failure with surgery.
You sound a little bit like a politician. You circumvene a little bit the question, but anyhow, I hand over to Wytske now. So the two pros and the two cons of biologics versus revision surgery. And sorry, I don't mean to be disrespectful, Eugenio, but it's like meant to be gossip around polyps, so it's not meant to be too serious talk here.
Well, revision surgery is relatively easy. It's fast. In experience hands, it's safe, and you can solve problems. As Eugenio also said already, anatomical problems. If there's a mucocele or if there are adhesions or other reasons, septal deviation. So in surgery, you can fix all at once. Biologics, well, you avoid surgery. I think that's number one reason to have a biologic. We're quite good now in getting patients into remission, so no symptoms after a year and no signs of disease. But we know if we stop the treatment that the polyps come back and the symptoms come back. So that is, I think, a major disadvantage of biologics. And of course, if we look in a more health economic way, biologics are very expensive. And patients, if it's paid by the insurance, the patient doesn't care whether it's expensive or not. But of course, for us together, it is important.
This brings me indeed to the next topic, which is kind of value-based healthcare. There is a cost associated with every approach. There are also practical considerations around biologics that can be self-administered at home versus revision surgery, for which multiple outpatient clinic visits and also hospitalization and anesthesia are involved. So how do you see that concept? Of course, in Europe, it's different than the situation in the US, but maybe how do you take the health economic aspects of both biologics versus surgery into consideration in Italy first and then in the Netherlands? So Eugenio, what are your considerations here?
I think that we have to consider that all we are doing now should be sustainable over the years. And so I agree with Wytske because the costs are a very important topic. And I don't think a massive use of biologic over all the population could be sustainable over the time. And
do you mean all the population or only those with nasal polyps?
Those with nasal polyps, thank you, to be
okay.
clarify. But this is a point, and because sometimes biologics are prescribed in patients that are moderate, not so severe. Because there is a group of patients with a moderate severe picture that probably they can start quickly. And in Italy, it's happening because there is a group of physicians that is prescribing biologic even before the first surgery. And the percentage is a little bit increasing. 3 years ago was 10%. Actually, I think the 20% is jumping. The 20% of patients treated with biologic didn't underwent the first.
That's a very interesting observation, Eugenio. That's very interesting. Do you see that in the Netherlands as well? Patients being treated with biologics even before they underwent a first sinus surgery, Wytske?
No, because in the Netherlands it is not reimbursed when you're not have had at least one sinus surgery. Mm-hmm. So if you want, there are a few patients that pay themselves. And of course, then you can choose whatever you like. But if the insurance company has to pay, then you need to have had at least one surgery. Yeah. And you need to have had the criteria we discussed before. So type 2 inflammation and symptoms and loss of smell and comorbidities.
What are in your center, Wytske, the most frequently encountered reasons for a contraindication for surgery? Is it patients being unwilling to undergo sinus surgery, or are there other medical conditions that do not allow a patient to undergo sinus surgery?
Well, in real life, of course, that very seldomly happens. We have some patients with very severe asthma. Where the pulmonologist is not very happy to have an intubation, but you can also do sinus surgery in local anesthesia. So I don't think that there are a lot of, say, hard medical cases that cannot have surgery. But of course, there are patients who would rather have directly a biologic and not have surgery before. But in the Netherlands, that is not reimbursed.
Okay. So it's interesting, Peter, that there are some data from registry that are not still published, that it's depending even from the specialist prescribing biologics. For example, if the prescription is performed from allergologist, it could happen more often that they will jump the first surgery. Not so often, but it is possible. And in Italy, it is possible only if the patients had a high systemic steroids use in the past, not in patients without this.
Yeah.
So I think that this is a problem that we will face in the future, because probably this percentage could increase. And this is my feeling.
Okay, maybe a last topic for discussion before we close this first Polyp Gossip episode, because time is running fast, and actually this discussion is very interesting for all listening to it. But I would like to know whether or not you think biologics will replace oral corticosteroids.
I am sure about that, because I think that in the future, no one will repeat without systemic steroids in that patient. Only in the emergency situation, like to control a severe asthma attacks or something else, but not for nasal polyps. I think that we shouldn't use any more systemic steroids so highly in that patients. And this is a clear situation of severity. If the patients have a high need of systemic steroids, this is a clear factor of severity for me.
I just wonder if Wytske agrees with this statement or might have a slight different opinion, which I can predict.
I agree, but of course, it totally depends on your health economic situation. Whether it's possible to prescribe, for example, in the UK, it's still not or very difficult to prescribe a biologic to a patient. And something we really have to work on together is explain to our health governance, to politicians and payers, that the cost of biologics is today, but the cost of systemic steroid use is in 10 or 20 years. And that's a difficult thing to make clear, because for many payers, they don't think further than the next month, maybe the next year, but definitely not the next 10 or 20 years. So that's a discussion we still have to have together and say, can we really, we more and more now know how damaging the use of systemic corticosteroids is, even relatively little systemic steroids. And are we willing to expose a patient to such a damaging treatment? Not today, but in 10 or 20 years. And can we defend that that's something we shouldn't do anymore, which I fully agree with Eugenio, we shouldn't. But I don't think it will be so easy.
Unfortunately, we have come to the end of this first episode of Polyp Gossip. And I would like to first thank my co-host, Professor Wytske Fokkens, for being such a kind co-host and also sharing her pearls of wisdom in the field of sinus surgery in relation to biologics, as well as our guest from Italy, Professor Dr. Eugenio de Corso, who shared his insights into sinus surgery and to what extent sinus surgery may help also patients in relation to biologics and also oral corticosteroids, as we heard at the end of the first Polyp Gossip episode. I would not like to end without thanking all the listeners and viewers to this first episode, because it's only with them and their views that we can expand our reach out and make sure that our patients get empowered by the right information on the one hand, and that also our colleague ENT doctors and also respiratory healthcare providers can also help their patients in a better way with the right information and with the right treatment. And don't forget, many more Polyp Gossip shows will be launched in the next couple of months, and the next episode will deal with smell impairment. We all know that smell impairment is a major issue, and it's largely neglected at diagnostic level as well as at therapeutic level. And exactly that's the reason why we want to focus on smell dysfunction during the next Polyp Gossip episode. So with that, I would like to leave you. I would like to thank you for your attention and take the pleasure of inviting you to the next Polyp Gossip show, which will take place in a couple of weeks.
Polyp Gossip.
This was Polyp Gossip, sponsored by Sanofi Regeneron and developed in close collaboration with EUFOREA.